rabies post-exposure prophylaxis. And then, of course, this diagram is beautiful if you are in a setting which has information about each and every animal that is being kept. For us, we don't have that in the country, so we rely so much on, wound care and the rest of it, and then which we are going to see, and then at the same time having a good post-exposure prophylaxis. So specific post-exposure prophylaxis for use in rabies, I think minor organisms start vaccine immediately. I think this also is not going to be very well, because they advise that you are supposed to see the behavior of these animals if they become rabid and rest. We don't have that time, especially in a country which is busy and developing, and you are focusing on other things. So, I mean, complete the post-exposure prophylaxis for rabies if you have been bitten by that. So we can go to the next slide again. Prevention and challenges. So control of rabies in domestic dogs are actually very important. People are advised to make sure that they vaccinate their dogs to prevent, transmission. Education and resources are lacking in this aspect, and very little funding has been put in this aspect of rabies. Pre-exposure prophylaxis, a 2 or 3 dose course regimen of vaccine is recommended for travelers or indigenous people like us who are in dog rabies endemic areas, because we are all having stray dogs moving around Kampala, moving around Gulu, moving around major cities, no one to feed them. You don't know their vaccination status. Ideally, we are supposed to have pre-exposure prophylaxis. And then, of course, people who work in the zoos. But because of cost, this is prohibitive. So what we do, we've center most on post-exposure prophylaxis at the time of the bite. Correct cleaning of the wound. Let us please have this in mind, that you have to correctly clean the wound. And then incorrect cleaning of the wound means you use adequate and copious amount of water with the soap. And if you have chlorhexidine or iodine available, you wash and rub that wound very well with that solution. And then, of course, optimum PEP post-exposure prophylaxis virtually eliminates the risk of rabies. Effective prophylaxis demands urgent wound care with a copious amount of soap and water, followed by vaccine. And if the wound is very big, you do rabies immunoglobulin, which is also very important. So that is our presentation on rabies. As you have seen, I've not mentioned anything on management of rabies, because all the other, there's a lot of, even the Malawi's protocol, there's a lot of challenges of, it has not been proven in clinical trials. The people who have tried it, the patients have died. So we don't have a very clear management option for rabies. And the information that I would tell people here is that when they come and they are clinically, presenting with the disease, they're likely going to die. So we have to make sure that we prevent them from coming like that. Thank you.
Thank you so much, Dr. Oriba. That was very informative. And of course, as audience, as you've heard, let us focus on prevention, because rabies...
Recording in progress.
Rabies is a deadly disease, so I think also education of the public is very important on the prevention method, mostly vaccinating their dogs, and also in case anyone who has been bitten by a dog, at least they can come to the hospital earlier for assessment, so that a vaccine can be given. For the questions, I request you kindly to type through our chats or the Q&A, because we have to go to the next presentation, which is botulism. At this moment, I invite Dr. Emuron to take us through his presentation. Thank you. Dr. Emuron.
Yes, thank you very much, Halimah.
I'm trying to share the presentation. I would request the last presentation to be stopped and then I can share.
Kind.
Okay. Yeah, I think we can see the presentation. Can everyone see the presentation?
Can you please switch on your video?
I'm not able to switch on the video, but I can be able to speak clearly.
All right, just continue.
Okay. Okay. All right. Thank you very much. Thank you very much, Dr. Oriba, for that elaborate discussion on tetanus and rabies. I think what I would add first on rabies is the aspect of pain management. It's really, really important to also consider pain management in these patients. You know, when they get those spasms, they really get damages in the muscle, and that causes pain. And Dr. Riva brought it clearly. You prevent the spasms, that's one way, but also you can bring on board the painkillers. And some of these painkillers can do both pain management, but also they help in sedation. Take an example of opioids. You can actually use them. And then the other could be paracetamol. The rest of the other things were clearly brought out. So I'm going to have a short discussion on botulism. And that's the outline. We'll just have a definition, talk a little bit about epidemiology, concentrate on clinical features and how to diagnose it, then assessment, treatment, and prevention. So botulism is a neuroparalytic condition caused by a bacterial neurotoxin that is produced by a bacteria called Clostridium botulinum. So it is kind of the same genus with tetanus, the Clostridium species. So this is Clostridium botulinum, and usually this bacteria is spore forming, and it can actually survive under certain conditions. So when someone gets these toxins, they can actually have a serious and potentially life-threatening condition. This disease generally is rare, and I would say in the practice personally, I've never come across it, but it is something that is important for us to watch out, because we can easily miss it out. About epidemiology, this disease, the bacteria itself is widely spread globally, and most of the time it's found in the soil, it's found in the rivers, it's found in the under the lake. So these bacteria, when the conditions are not favorable, it can actually form spores, and those spores can stay for a long time. And then when the conditions become favorable, they can actually now germinate and the bacteria starts multiplying. And this bacteria is an anaerobic type. It's a gram-positive and an anaerobic. It thrives well in conditions where there is no oxygen. And there are different strains. They strain from A to H, but the ones which are really implicated in producing toxins which are cause serious implications on humans is A, B, and then you have the H, you have the G. So the C and D, usually they're implicated in birds. And when I was looking at the literature, in Uganda, for example, there have been reported cases. There was a reported the outbreak. I would call it kind of an outbreak. In 2008, one of the schools, 3 students at the suddenly got sort of descending paralysis, and they took those students to the hospital and they took samples. And after they analyzed the sample, they found that they had the botulism. And when they looked at the source of the botulism, it was actually found out that these students had taken this oil. I think for us who went to school, they used to call it flavor, but I think the bacteria had infiltrated in the flavor and they happened to eat the same flavor, and then they got the disease. One of them died and the other two survived. So in terms of incidents, I've seen cases reported in Eastern Europe, and that is in Georgia. And then also in Africa, Nigeria, Ethiopia, there are really not so many, and they're usually isolated. It's in Ethiopia where they reported a large number of people, mainly due to the practice, the way they preserve their milk. They keep it, and sometimes the milk actually can have the bacteria and produce the toxin, then people consume. There were about 70-something people were affected. And the transmission, you can actually get the toxin or the bacteria through 3 ways. One, you can ingest the bacteria when it's contaminated in food. And then the other is inhalation. This is common in people who kind of work in a lab. And then the other is wound contamination. So maybe you get pricked by a thorn, you don't take good care of the wound, and then the bacteria starts growing and starts producing the toxins. So the pathogenesis, basically these toxins, once it's produced, either you've ingested it or you've inhaled it or you've actually gone through the wound. The toxin goes and binds on the presynaptic membrane. Now it enters inside, and when it enters inside, it actually interferes with the protein called the snare protein. Now the snare protein is the one that's responsible for getting the acetylcholine vesicles onto the presynaptic membrane so that they get into the cleft and it goes on to activate the muscle, usually common in skeletal muscles. So if the acetylcholine cannot go and bind to the receptors, that means you are going to get paralysis. So the hallmark of this disease is that it causes neuroparalysis. And the clinical presentation can range from really mild to life-threatening, and also intubation period varies depending on the type. But generally, the way you can be able to be confident in saying that this is likely to be botulism. One, it is mainly symmetrical, descending symmetrical paralysis. And in this case, most of the time, the patient will not have fever. But in case you have a wound, inoculation through the wound, you may get an infection and then you may get fever because of the wound. But the other routes, in most cases, you don't get the fever. And then you may have visual deficit. Some people may have photophobia. Some people may have double vision. And then the other thing, but the other the sensory part of the nervous system is not affected, and even the other senses are not affected. And then the patients usually, they are kind of alert and responsive, and most of the time it doesn't affect the vital sign. That's the general symptom that make you highly suspicious this is botulism. However, there are different types. We have the infant botulism, and sometimes it's called the floppy baby syndrome. And it's a most common type of botulism, and usually affects children between 1 week to 12 months. So now, what is said is that we all know that the gut of the babies is not well developed, and it does not have some of the floras to kind of prevent multiplication of the bacteria. So in that case, when a child takes milk and maybe there is the bacteria there, the bacteria can actually start growing and producing the toxin. And as some of the toxins involved, the strains is A, B, E, and F. And the symptoms are usually the child will get things like constipation, poor feeding. Generally, these are not specific, but the one which makes you more suspicious is you can see that picture, a floppy baby. You try to hold the babies completely floppy. Then it's also thought that some of this botulism is more likely to come from there's honey. If you give the this bacteria, and when the honey, it actually causes and then produce a toxin. And we have the foodborne, and the foodborne just you ingest either you ingest the food that has the bacteria and the bacteria produce a toxin, or you actually ingest and the bacteria gets to grow and then produce the toxin. So so you get things which are non-specific, like nausea, vomiting, no, really non-specific. You go on getting things like dry mouth, sore throat. Then later on, you see things like vertigo, dry eyes. Then now it has affected the nerves, really. You see the effects on the nerves. You get things like ptosis, and then fixed, dilated and fixed pupils, dysphagia, things like flaccid paralysis, which is actually descending. That one is really key. Paralysis that is descending. And if this paralysis descends and reaches the respiratory muscles, you actually get difficulties in breathing. And when it reaches this stage, it's really is fatal. And remember, in most of our settings, we do not have the capacity to provide critical care. There are no ventilators, but also there are no ICUs. And then the last one is the wound botulism, which that one usually takes some time, because sometimes when you get the wound, it takes some time. If you don't take care, then that bacteria has to, the spores, you pick out the spores, it grows and then produces the toxin. And with it, of course, there might be also some other secondary infection in the wound. And in this case, you may actually have fever. But the rest of the other symptoms, once you get the toxin into the bloodstream, goes to the nerve, you get the other symptoms like stated in the foodborne: vertigo, dry eyes, ptosis. So really, the diagnosis in this case is mostly clinical, and you take your history very well and then examine the patient, and then there is laboratory detection of the toxin. You can either detect it from the serum, the stool, or the food. But in our setting, really, the capacity to do that, and even if you're to do that, it's going to take time. The other one, you could culture the bacteria, but culturing this bacteria is very difficult in the lab because of the conditions it requires. And then in the assessment, really, when you see this patient, when you go through the ABCD assessment, you're really concerned if it has affected the paralysis has moved down to involve the muscles of respiration. So you'd be worried about your B, and in that case, your patient might need respiratory support. And in the C, most of the time, unless maybe someone has had serious vomiting, diarrhea, you may get changes in the BP. But most of the time, the vitals are normal. And then look for, you must really look for signs of respiratory paralysis. The rest of the other things, you go through the ABCD, whatever you get, you can you get it and you sort it, you correct it. The treatment, it's very difficult to know whether someone has really ingested this, because the bacteria first of all will not have like a specific smell. But if you're highly suspicious, you can actually do and you're within the time frame when the person took the food. If you suspect, you can do gastric lavage, but that really won't help much. Then you can use the antitoxin, but even this one, it is rarely available in our setting. So the management really is largely dependent on supportive care, depending on what problems the patient has, and if it is involving paralysis of the respiratory muscle, this patient needs to be intubated and ventilated until the effects of the toxins wear off. And the antibiotics, you can use it in the case where you have a wound, inoculation through the wound. And the vaccine, I've seen that there is a vaccine for this, but however, the efficacy and even then its availability, and then the side effects, they are not really good, and it's usually reserved for people who work in the lab. Those ones who are kind of likely to get it exposed. Then there's some of us have heard of this, the Botox toxin A. This toxin is bad. It can give you the botulism, but also scientists can extract the toxin and use it for other benefits. We've heard of treatment of wrinkles using the botulinum toxin. We have heard of cases where someone might have, for instance, hemifacial spasms, specific spasms in some area. You can inject the toxin in the nerve and prevent. And then also some cases of achalasia. So prevention of this, it's really important. And recently we have had cases where we've had like food poisoning breaking out in school. It could be one of these, it could be botulinum leading to those kind of outbreaks. So it's really important to prevent. And in the prevention, basically for the ingestion of foodborne botulism, we've got to make sure that we keep the food properly, especially that food which is left kind of open, the bacteria and the closed, and you've covered it. The bacteria can go in there and then start multiplying. And then we need to really boil our foods properly at temperatures of 120 degrees Celsius. You boil your food with high temperatures, it can kill the bacteria and also kill the spores. And then for the honey, I mentioned that in children it's really more common with the honey. That's what the literature says. And we can avoid giving children honey, and generally avoid preparing food and keeping them in cans at home. And mostly that then the people who get wounds, those wounds should be really cleaned and managed properly. So those are some of the ways we can prevent. So in summary, really, the take-home point is that botulism is rare, but it's a life-threatening disease, and we've got to be on the lookout. There are other diseases that can actually present the same, like botulism, descending paralysis. Things like snake bites, some Myanthenia gravis, things like GBS, so and some other kind of poisoning. Dr. Oriba mentioned some of them. They kind of present the same way. So we must be on the lookout. And if you remember the specific clinical features which kind of set it apart, that will raise your suspicion. Thank you very much for listening.
Thank you so much, Dr. Joseph Emuron, for that elaborate presentation on botulism. At this moment, of course, I request the audience still to post their question through our Q&A or our chat. Dr. Olum will be answering them. But then, Dr. Olum, in case you have any key questions to Joseph, you can kindly maybe ask him before you go to the nursing care. As we wait for Dr. Olum, are you there?
Yes, I am on. Come again? I didn't get you.
Yes, I do have through your chats. Do you have any question that is directly towards Dr. Emuron presentation that you may want him to answer? Key question.
Well, I think what I'll say is most of the questions been answering them through the chat, but there are just a few things I probably would like to highlight which came out. I think, but this is going to now involve both questions. I'll be brief. Antibiotics, metronidazole. Oh, okay. Sorry, I've seen that they requested they want to see my face. So one is antibiotic metronidazole is best preferred for treatment of tetanus. So Dr. Oriba mentioned that, but I think we should take it at least the first line. The other drugs in research has shown that their mortality outcome is not good. So when you give other forms of antibiotics, unless you have any symptoms, that is the only thing for tetanus. For diagnosis, for rabies, you mentioned most of the things, but you can also get skin biopsy from the neck of this patient, saliva, and you test CSF. Rabies vaccine, if you've already given the vaccine 7 days, it is not useful to give the antibody later, because by 7 days, normally these patients have become the immunoglobulins already. And remember, the immunoglobulins do not cross the blood-brain barrier, so that's why when you get rabies and you get already clinical presentation, even if you give your immunoglobulin, the patient is not going to now get better because it has encephalitis, and then your immunoglobulin will not help. So about botulism, yes, the vaccines are really not doing well, so the guidelines actually don't even talk about giving it. So no vaccine for botulism. I think those are the only clarifications I wanted to make. Thank you very much.
Thank you so much, Dr. Olum, for answering those questions, and keep on answering those questions that are coming through your chats and Q&A. So at this moment, audience, you've heard the epidemiology, the management from the doctors, and of course, and other interventions that can be done to manage all other conditions. But of course, when these patients come in, as the doctors are doing their management, also it's a team. We did the nursing care. So with us, we have Nakiganda Catherine, the care nurse from Mulago, who is going to take us through her presentation. Over to you.
Thank you, Halimah. We are going to look at the nursing care of patients with the various conditions that have been talked about. But as you've all heard, most of the care has been hinted on by the various presenters. So I will dive into the critical care management, especially in the ICUs, looking at the nursing aspect. Like we've seen, all these conditions affect the nervous system, and they lead to they interfere with the function of muscles, either increasing their activity or actually blocking and paralyzing the activities completely. So as a nurse, your operations would be looking at wound care, like one of the specialists that's talked about. You need to care for the wound with a copious amount of fluid and soap, and you can also use hydrogen peroxide, given that these bacteria are not friendly with oxygen. As we've seen, most of them are anaerobes in nature. I also want to look at the nutrition support because these patients are expanding a lot of energy and they need nutrition to recover. Then also we look at airway management, analgesia, and patient positioning. We also look at the cardiovascular consideration, cardiorespiratory consideration. We also want to prevent complications that may arise as you manage these patients, and also as they recover, we want to look at physiotherapy and rehabilitation. So I'm going to run through this slide so we cannot be catching up with you. Next slide. So in wound care, for tetanus patients and actually for all patients, because we've seen that the most common point of entry are wounds, either a dog bite or a nail or a bad bite. So the wounds need to be cleaned daily, and one of the doctors said the wounds really don't need to be covered so that we ensure good aeration. For the tetanus patient and rabies patients, you're advised to nurse them in a dim, quiet environment, preferably well ventilated. We want to minimize stimuli. So as you're nursing your patient, you need to cluster care, come in, do most of your care at the same time, and then leave the patient to rest. Then we want to administer the prescribed medications on time, especially for the tetanus patients. We've seen we need to ensure that they are as spasm-free as much as possible. So these medications need to be given in time, the sedatives, the antibiotics, and the immunoglobulins, so that we can get a good outcome. Also, these patients, they need to be given, you need to have an NG tube food so that you can feed them well, but also to prevent them from aspirating, as we've seen that aspiration is one of the complications that they can develop. We also, you also need to ensure that they have a urinary catheter in situ so that they don't get complications of bladder spasms, which can lead to autonomic dysfunction, which is also not a good complication for these patients. We also need to administer fluids, so we need to ensure that we have IV access so that we can give them fluids, as we've seen that they can become very diaphoretic, and also in tetanus, the patients may produce a lot of myoglobin, which can also affect the kidneys. So basically, we've seen that all these patients may end up needing ventilatory support to ensure that their airways and their respiratory system is protected. So we are going to look at how to manage a patient on ventilation. As a nurse, you need to ensure that that tube is patent, so you need to frequently suction the tube. We also need to position our patient well. We need to prevent the patients from getting the ventilator-associated pneumonia. So we have what we call the VAP bundle in the ICU, and the VAP bundle involves elevating the head of the bed, and we want that head of the bed to be around 30 to 45 degrees so that we prevent patients from aspirating. We want to give them sedation because they're having spasms, and and those spasms can affect our respiration. So we give them sedation, but also we need to give them some sedation holidays to see how they are faring, because when you leave them sedated for a long time, then they can develop more complications. We want to give them PPIs prophylactic for they may develop some stress ulcers, so we want to give them that prophylaxis. And also we want to give them thromboembolic prophylaxis, because they are bedridden. They can easily make clots, which can worsen their condition. Also, we want to do oral care, because as the patient has a tube, then we have micro aspirations, which can introduce bacteria into their airway, causing other infections. And then as on the ventilator, I want to give them spontaneous breathing trials as they're improving. So that is all part of the VAP bundle, ventilator-associated pneumonia prevention bundle. We've talked about giving them adequate fluids, as of course prescribed, because they are prone to dehydration and electrolyte imbalance. We want to manage their fevers. As we've seen in tetanus, patients tend to have high fevers, and we want to monitor and manage them. We want to regularly monitor their vital signs, because we've seen as the disease progresses, patients can develop arrhythmias, but also they come in when they are not ventilated, and sometimes they fail to protect their airway. So if you're not monitoring their vitals, you will not know when you actually need to escalate care. And also, because they are bedridden, you want to turn them, you support them. So we do a 2-hourly turning to prevent them from developing other complications like bed sores. Next slide. So in the ICU, we have what we call the fast hugs. It's an acronym for what you should do for the patients as you take care of them. So in the first, we have F, which stands for feeding. Patients should be fed regularly with high caloric foods so that they can get enough nutrition for recovery. We should give them analgesia to ensure that they are not in pain. Then also we should give them sedation, thromboembolic prophylaxis, the head of the bed, as I talked about it, the ulcer prophylaxis, the glycemic control. So you'll be checking their Rabies frequently, at least probably every 8 hours, to ensure that their glucose levels are within acceptable ranges. Usually in the ICU, we want their glucose to be between 7 to 10 millimoles. And then we do a spontaneous breathing trial to see how our patient is improving, because we would want to take them off the ventilator as soon as possible. Then we do bowel care to ensure that they don't get constipated, as we've seen that constipation can also lead to autonomic dysfunction. Then also, they should have that indwelling catheter, and then we should think about the escalation of antibiotics and probably fluids and all other things as the patient gets better. Yeah, basically that is the acronym for managing. It cuts across the patients in the ICU. It helps you cover up patient care holistically. So when I looked at prevention, they've talked about prevention, and the best way to prevent is through vaccination, and for tetanus and rabies. And tetanus, every after 10 years, you need to get a booster dose. So you need to educate your the patients and attendants, and also wound care with copious water and hydrogen peroxide. I'm going to skip some slides there. And We're going to go to slide number.
The important ones, the education.
Slide number 15. Botulism. Okay. So when you go back to, let's go back to rabies. When you talk about rabies, like the doctor said, rabies literature has shown that when patients have gone into the severe form of rabies, the management is futile. But when we look at the aspect of nurses when they're managing patients with rabies, they advise to protect yourself as a nurse, and you need to have good IPP protocols. So when this patient gets ventilated, they think that the rabies, the virus can aerosol. So you need to have a mask, use gloves, use gowns, and also patients needs to be isolated. So on prevention, I'm going to look at prevention in botulism, although your doctor talked about it. It's slide 15. So as a nurse, we should ensure good hand hygiene, both for the nurse and for the attendants and the patient. As we health educate these patients, we should teach them good hand hygiene to prevent the ingestion and the contamination of food, proper food handling through the World Health Organization safer food protocols, where they advise you to keep clean, separate raw and cooked food, cook thoroughly, and keep food at safe temperatures, and use safe water and raw materials. Then also we avoid contamination of food by soil, and then preserve homemade food and ensure that it is well handled to prevent it from being contaminated by spores. And then still proper wound care, because we've seen that botulism can be wound botulism or food botulism or infant botulism. I think that's it. Thank you.
That's it. Okay. So we've come to the end of the nursing care, and she managed to go through the slides very fast because some of the issues had already been talked about by the other experts. At this moment, maybe we'll open up reactions, just giving opportunity to like 3 people to ask questions. But before that, maybe I can add something, mostly on the area of rabies. Rabies being a deadly disease, as doctor said, I think the psychosocial support should also be emphasized, because in most cases, these caretakers will come in with a patient, and of course, you tell them that this disease has no cure, but of course, you need to lay their anxiety. So that, of course, even if this patient is going to die, of course, they will appreciate you as a health worker, because you've taken them through the process of course, the prevention and the rest up to the end of course, the dying end. And someone asked about isolation. The isolation, I don't know whether you can talk briefly about it. The isolation of these patients, yeah.
Of all these patients.
Mostly rabies and tetanus.
Well, literature has it that patients with tetanus need to be in a quiet environment that is with dim light and well ventilated. So isolating them in an environment, in their own room, can help us create such an environment where we do not stimulate them to get spasms frequently. So it helps them not develop risks for respiratory dysfunction because of repeated spasms. Then for rabies, when this patient when they are vaccinated, when they are intubated, the Russia says that the virus can be aerosoled as you're suctioning. So and also it can easily be spread from one patient or from one person to another. So the need for isolation when you're managing these patients.
Thank you so much. And also protecting yourself by putting on the appropriate PPEs. We are running, but I kindly request like 3 people to raise up their hands and ask a few questions related to the topics that have been discussed as we come to the end of our sessions. But before that, of course, we are going to display the poll sessions. Keep on filling in them as we answer our questions. Thank you. As wait for participants to raise their hands, and maybe I request one of our experts who are online to give us a take-home message concerning the diseases that we've been discussing. Maybe I can start with Dr. Oriba. Can give us highlights and a take-home message of what we've been discussing. Thank you.
Yeah, thank you very much to all our listeners and the health workers who are on the forum. I think we have to appreciate that rabies is a vaccine preventable disease, and awareness both at local awareness is very important. We have to increase health education to our patients who visit our facilities. Even during church visits, you go to the church, you can pass on this information so that at least, we prevent patient coming with the clinical diagnosis of rabies. For tetanus, I would advise that Maine has been neglected. I'm a pro man, and most men are dying from tetanus. So I would also like to encourage that we have Maine also enter the program of vaccination. Why? Because Maine don't give back, and so so the process which has been put by other for protection of women doesn't apply to us. So we should encourage men to get vaccinated. For botulism, it's very rare, and I think it's high index of suspicion and management. But otherwise, let us emphasize vaccination for patients who come with, who get exposed to tetanus and rabies. Thank you very much.
Thank you very much, Dr. Oriba, for that take-home message. Next expert, Dr. Emuron.
Thank you very much, Halimah, and thank you very much to the team that has managed to join and we learn this together. On my side, I think recently in my area, we found out that a certain quack person in the village was actually getting patients who were bitten by dogs and saying that he anti-rabies, and he was injecting them some things we don't know. And all these children, we had like 3 children. They came to hospital when it was already late, and the message here is what Dr. Rivers said. We really need to sensitize the community. And sometimes those people, when they come, we really need to ask some questions like where they have been. And if we discover such a thing, I remember in our instance, that person was taken to the legal team came in at the police, and then actually that case ended in prison. So we must be aware of those other people, and we must educate our people. Prevention, prevention, prevention. And then for botulism, we must really think about the way we store our foods. Sometimes we keep them in ways that can actually encourage the bacteria to grow. And when we get some like an outbreak in schools, you must think about it. And yes, for tetanus, again, the same thing, prevention, let them encourage the men to get vaccinated. Thank you very much.
Doctor, thank you very much for the take-home message. But before you go off, we have the session post-test there. So can you kindly talk about the correct answers there and why? The poll question.
Yes.
Yes,
for number one.
Yes.
The food most likely to be contaminated with botulism. I've already addressed that. It's actually those foods which we try to kind of store at home, and the way we store them, the conditions the bacteria can get in and grow, and the answer is B. And I see most people have got it right. And then the second question is the symptoms of food botulism. So the answer is all of the above, because usually when the toxin affects the nerves, you get the muscles involved in the sight, the eyelids, the speed affected, and the right answer is all the above.
I think those are the questions that were set by you.
Yes.
Okay. So the next question, that is number 3 on the nursing consideration of managing botulism. That one was set by Catherine. Catherine, kindly give us the correct answer there and also your final take home.
The correct answer is A, and as we've seen, botulinum toxicity causes ascending paralysis, and you would worry about respiratory involvement, because as the respiratory system gets involved, then the patient will fail to breathe. And the botulism doesn't cause spasms. So the answer is A.
Yeah, and do you have any take-home message?
My take-home message does not differ much from the rest. These conditions are preventable, and vaccines are available. We should sensitize masses to get these vaccines. For example, in our country where we have a lot of rabid animals, dogs, all over the street, we should be advising people to go and get pre-exposure prophylaxis, so that in case an incident happens, it finds you with some bit of immunity, and then also sensitize them to know where to find these vaccines when they need them, because some of you find some of them are not available in some of our government institutions. Then also back to men, you find that tetanus actually affects more men than women, because women get a chance to get vaccinated when they are pregnant, but also in schools, the government has put up systems for the girl child to get vaccinated, but the men are not catered for. And then we see quite a number of them coming with tetanus in the hospital, and actually a big number succumbs to this disease. So we need to advise them, encourage them to go and get the shot.
Thank you very much. And move to the last question that was set by, I think still, I don't know, emergency department with trismus, vomiting, and hypoxia, reports minor trauma while playing outside several days. So you do have to answer that question. Yes.
I said to that question.
Thank you. Go ahead.
The answer is D. 12-year-old male presented to the emergency department with the features of tetanus, I think we can see. He reported minor trauma while playing outside. So we want to look at clinical diagnosis of tetanus. You don't have to, gram stain, the heel is only 30% or less. Isolation in blood cultures, very tedious, you can't do it. Wound swabs, you can't do it. Serology, there is no much test. So I think the answer there is the clinical diagnosis. So that is what we are taking. And then the last one, a 26-year-old male present 3 days after a dog bite. What diagnostic test aids with ascertaining exposure to rabies? Serum IgM, skin biopsy, mucosal IgG, whole blood PCR. It's none of the above. Once someone has told you they have been bitten by rabies, at that point in time, 3 days, the virus has not yet started multiplying very fast. So you are going to miss all these things. So what you are going to do, you are just going to vaccinate this person, give them post-exposure prophylaxis, and depending on the degree of the wound, you can also give immunoglobulin if rabies has been confirmed in that dog. So those are the two answers. Thank you.
Thank you, Dr. Oriba. We have one hand up, but before I invite Sharifa, just hold on there. That will be our one and last question. And let me also invite the other two experts to give us their take-home message. Dr. Kedi, are you there? We are done with the poll questions now. Dr. Kedi?
Yes, hello.
Yeah.
Am I allowed
take-home
to-
message?
Yes, the take-home message here is prevention. And another important thing is about tetanus is if you get these patients and you're in a low setting that you're not able to really to manage, it's better to refer this patient to a place with a ICU setting because we are scared of the airway. So that is very, very important. Looking at the patient that we had in this case, it was a very difficult case for us, and the patient could not, the caretakers did not accept to be referred, and it was really, we were in a dilemma. So what is important is to get this patient referred to a place that has ICU services. Thank you so much.
Thank you very much. Last, I come to Dr. Olum, who has been managing our chats, the Q&A, very well. Dr. Olum, your take-home message to the participants.
Thank you very much. You might not see my face now, unfortunately, but thank you. I would like also to give a highlights. There are some questions which came up, which I think is important. One that when a patient comes and you has a wound and you want to give them treatment, there are two things. One, the patient can come and has a clean wound or a minor wound, or they have a dirty wound. Okay, so for a patient who has a clean wound or a minor wound, and you don't know whether they have received all the doses of the tetanus vaccine, you give them the vaccine. Because with a clean wound, the suspect is that the risk of getting tetanus is low, so normally it's not advised to give immunoglobulin. If you have a dirty wound and this person has unknown duration of whether they have gotten the 3 doses or they have gotten less than 3 doses, and the wound is dirty, and you think there is a high suspicion for getting tetanus, you give them the vaccine plus the immunoglobulin. That is the guideline. That is the standard guideline by CDC. The other one is if you have somebody who has gotten all the doses, okay, all the 3 doses, and the last dose was more than 10 years ago, you are going to give them the vaccine in a clean wound, not immunoglobulin. But if you have a dirty wound, you're going to give them the vaccine and you don't give them immunoglobulin still. If they have got the last dose more than 5 years ago, but not more than 10. So in between 5 to 10 years, you still will give them the vaccine only. So I found that one typing it would be hard, but the guidelines are there online. You can actually find out from that. Like all my colleagues have said, we've done studies in Lacor, we found that men are dying more than tetanus. For women, because when they reach menopause, they don't get the TT, they come later. So the older women are the ones who are normally found to have tetanus. Thank you very much.
Thank you very much, Dr. Olum. We are coming to end of we've come to the closure of our session. But first, let me thank all the participants who have managed to join in, answer our poll questions, and also the post through the chats, and also those who have managed to ask questions. Thank you very much. I hope all your expectations for this session have been met. And next time when you come across such a patient at your different facilities, you'll be able to save a life. I thank all the experts for the elaborate and informative information that we've managed to share with us. Thank you so much. And special thanks to Minister of Health, Seed Global Health, all the team who has always made sure that these sessions take place. I remain yours, Halimah Adams, your moderator for today's session. And next, please, screenshots, kindly switch on your videos for photos and sensors. Thank you so much. Wish you a blessed evening and make sure you're counted.
Excuse me.
I forgot Sharifa.
You forgot me completely.
Oh, as we take the screenshots, Sharifa, kindly ask your question.
My question was about I need more light about honey, because when it comes to management of wounds caused by burns, we've been using honey, of which you said that honey is a risk factor for getting botulism. So we need more light about that honey.
Dr. Emuron, kindly.
Yes,
Yes.
I mentioned about the honey, and I was referring it more to the infants, and the reason for the infants. For the adults, you have a well-formed gut, and there are some other bacteria that can prevent the other from multiplying. But for the infant, given the maturity in their gut, that's when that's the reason why if there is any spores in the honey, it can actually multiply. Now, when it comes to wounds, that we normally use the honey. Most of the time, the way we apply that honey, we clean the wounds properly, and then we actually sometimes we apply and leave it open. And we remember that this bacteria is anaerobic. You need to create that environment that actually favors the growth of the spores. So in that case, you hardly the wounds normally remain kind of open, and that prevents the bacteria from multiplying and giving you the toxins.
Thank you very much, Sharifa. I hope your questions have been answered. Bye, everyone. Do we have someone from, I can see Simon Oriokot from Yumbe, and Columbus, Sharifa from Kayunga, and yes, thank you all participants. Bye.